Welcome, everyone. We'll just wait a minute or two to get started. Okay, the speed of new people joining us has trickled, so I'm going to get started. My name is Susan Buskin, and I've been hosting the Lunchbox talks since Martina Morris and Bob Wood handed it over to me a few years ago. The Lunchbox talks are jointly presented by University of Washington and Public Health Seattle, King County, CFAR, and our goal is to foster more joint activities between those groups. And I think we've been pretty successful in finding people from the best of all those worlds to give our talks. So I'm really excited about today's talk. It will be the first time our summer Pride survey results have been presented to anybody. Both of our speakers are extraordinary PhD students at the University of Washington in the Department of Epidemiology. I'll introduce them both, and then Mike will start and Diana will follow. So to start, Mike Berry is an epidemiologist in our HIV STD program at Public Health Seattle and King County. Mike has worked in HIV for about 8 years, including 4 of them at the county health department. It's a joint city county health department. And Mike's research interests include the health of LGBTQ plus people, people who inject drugs, and people who participate in sex work. Mike will be presenting the demographic, HIV risks, PrEP, and COVID-19 related data from the core Pride survey this summer. And a fun fact about Mike is that he is double jointed in both thumbs. Cool, Mike. Okay, and now Diana, she is an NIH Ruth Kirstein predoctoral research fellow. Diana has also been working with in the HERBA group with molecular surveillance data too. Diana has over 10 years of experience with LGBTQ communities. Her research interests include queer and transgender health, sexual health, and HIV STI prevention, also molecular epidemiology. Diana will present data on a supplement that she worked on with her community advisory board, looking at barriers to care and discrimination experiences among LGBTQ people. And Diana's fun fact is that she calls herself a musical theater nerd, and she's seen Jesus Christ Superstar live over 100 times. I think you're too young to have done that, Diana. I can't believe that. But anyhow, a big welcome to Mike and Diana. And Mike, you can take it away.
Thank you, Susan. Can everyone see my slides okay? Looks good. All right. Okay, so today I'll start with a brief background on the Public Health Seattle King County Pride Survey, including our motivation for administering it each year and describe survey methods. I'll also present descriptive data from the sample of participants who took the core survey, and as Susan mentioned, Diana will lead the second half of our session and focus on the results of the supplemental survey. And at the end, we will have time for question, answers, and discussion. Also, please feel free to type questions in the chat as they come up. So a quick background, the PHSKC Pride Survey has been administered each summer since 2009, primarily at the end of June around Pride events. In 2020 and 2021, the survey was done online. The goals of the survey are to capture within the LGBTQ plus community important data on HIV and STI risk and service use, access to other healthcare services, and awareness of and responses to public health campaigns and prevention strategies that are aimed at this community. This survey is particularly important because it allows us to interface with members of the community who might not be interfacing with, say, for example, services at the sexual health clinic. It also more broadly allows us to talk to people from outside of the immediate Seattle area. And as Diana will speak to a bit later, this survey allows us to work with community members and stakeholders in the region as we craft our conclusions from the survey and consider future iterations of it. So some brief info on the methodological changes because of COVID. Public health made changes to survey implementation starting last year, which largely carried through to this year. So before 2020, the survey was administered in person at Pride events during Pride weekend, which is the last weekend of June. To be eligible, participants had to live in Washington state and be either a man who has sex with men or identify as transgender, non-binary, or genderqueer. Participants all received a $5 coffee card and swag bag as an incentive. And in 2020 and 21, participants were able to take the survey online using a red cap instrument, which was promoted online at virtual Pride events and on social media, and was available from late June through August. To be eligible, participants had to live in Washington state still, but could be essentially any member of the LGBTQ plus community as outlined here on the slide. And the incentive was the chance to win one of 5 iPads. In most years, the survey has been available in both English and Spanish, including this year. Our sample this year was 2,726 individuals clicked into the survey and were screened for eligibility. Of them, 2,275 were eligible and completed the core survey and were entered to the iPad raffle. And of them, 1,560 took the supplemental survey. Here, I'll show you a very fun GIF that was used to recruit participants online. I know I would have clicked through this if I saw it come up on my phone or computer. And here we see both English language and Spanish language recruitment flyers that were used to recruit participants. A brief terminology and abbreviation orientation. You'll see these used throughout my section and certainly Diana's as well. So cisgender, or simply cis, refers to any person whose current gender identity is conventionally associated with their sex at birth, or more simply, a person who is not transgender. Non-binary is an umbrella term that describes a person who doesn't identify with binary genders, such as man or woman, but instead perhaps gender fluid, gender queer, or one of the many, not just these gender identities here, but one of many other gender identities as well. And finally, trans or transgender is an umbrella term to describe a person whose gender identity is perhaps not conventionally associated with their sex assigned at birth. On to core survey results. Participants represented every region in just about every county in the state, as you can see here in this lovely graphic that Diana put together. Overall, 59% of participants were here in King County. 75% were in King County or a neighboring county on the I-5 corridor, including Snohomish and Pierce County. And 8% were over in Eastern Washington, which are the counties circled here on the slide. Here I present a breakdown of participant gender identities. This year in the survey, participants could select more than one gender identity as well as write-in gender identities. So we sat down and went through what those were. And then we had to make some decisions about classifying gender for purposes of today's presentation. So I'll briefly walk you through what those were. Individuals who took the survey and identified only as cisgender are considered cisgender women or cisgender men. Those who identified only as non-binary or another gender identity, such as one of the ones listed on the earlier slide, were considered as such, and that's the kind of teal piece of the pie over here on the top left. And then those who identified as either a transgender man or a transgender woman were considered as such, regardless of which other genders they may have identified with. For example, a participant could have identified as a trans man and as non-binary. For the purposes of today's presentation, someone in that situation would just be considered a trans man. And those are the kind of pale green and purple colors that you see here on the bottom left. Among all participants, 64%, about 2/3, were cisgender, among whom 59% were women and 41% were men, and that's the gray and the black that you see here. And in the remainder of participants, 36% of whom identified as not cisgender, 10% were trans women, which is 3% of the total participants. 16% were trans men, which is 6% of all participants. And 74% had an additional gender identity. And as I mentioned, people identified as multiple genders. Within the classification of transgender men, 42%, this light blue, identified with an additional gender identity. And among trans women, 27% identified with an additional gender identity. And later on during Q&A, I'm happy to speak to what those were. Here I present the racial and ethnic identities that were in the survey. Participants could select any or multiple ethnic or racial groups that they identified with. Here I present the number of people who selected each racial identity as a proportion of the total times groups were selected. So that is to say that participants were counted multiple times in many instances. Relative to the population of the state at the 2020 census, the sample of 2021 Pride participants had higher representations of white people and lower representations of Black and Asian people. Briefly, this is a histogram of age distribution of participants. The youngest person was 9 and the eldest was 81, and on average participants were in the mid-20s. I'll take a moment here to show you this histogram. It's the same data broken down by gender identity, and you can see on the right-hand side here the gender identities listed. And really this is to highlight that there were some differences in age. So cisgender men were the oldest group with a mean age of 41. Women, both cisgender and transgender, had a mean age of 37. Non-binary people had a mean age of 33, and transgender men were the youngest group with both median and mean age of 29. Here I'll present education, income, and insurance status data from the sample. I want to highlight that poverty was common, with more than 1 in 5 participants overall reporting an annual income of under $15,000. Examining the same data stratified by gender identity, we found disparities in education and income, but not in insurance status. Notably, transgender women and men had low educational attainment compared to cisgender people. And transgender and non-binary people, particularly compared to cisgender men, had alarming levels of poverty, with about 1/3 reporting an annual income of less than $15,000. The same data stratified by race and ethnicity also revealed disparities. Notably, Black, Latinx, and this NHPI refers to Native Hawaiian and Pacific Islander people, had lower reported lower educational attainment, and all people of color, particularly Native American and Alaska Native people, excuse me, had higher levels of poverty than white participants. And Latinx participants had extremely low levels of insurance coverage compared to other groups, with 19% reporting no coverage, though there's also a notable disparity among Native American and Alaska Native participants as well. Here we examine experiences of homelessness and housing instability. Participants were asked in the last 12 months, had you lived on the street or in a shelter, hotel, or car, to which 3% overall said yes. We did not notice clear differences in this data between gender identity groups, but disparities were observed on racial and ethnic lines. So 5% of Native American and Alaska Native participants said yes to this question, 7% of Latinx participants, 9% of Native Hawaiian and Pacific Islander participants, and 11%, or 1 out of 9, Black participants said yes to this question. We also examined experiences of sex exchange. Participants were asked in the last 12 months, did you have sex in exchange for money, drugs, or other needs? To which 2% said yes, and notably a sort of small proportion said that they didn't know, that black bar there on the top. When we looked at the gender identity breakdown, we found that 7% of transgender women said yes, while the same proportion was 3% or fewer for other gender identity groups. Examining this question by racial and ethnic stratification, we found that 14% of Native Hawaiian and Pacific Islander participants reported exchanging sex in the last year, compared to 2 to 4% for other groups. We asked participants whether they'd had vaginal or anal sex in the last year without a condom with a non-monogamous partner. Overall, 65% reported doing this. However, when we stratified by gender identity, we found that for, and I apologize for the tiny labels, transgender women, trans men, non-binary folks, and cis women all reported between 50 and 58% said yes. And 90% of cisgender men said yes to this question. And this likely reflects the HIV and STI incidence patterns that we see across the state, particularly here in King County, where 69% of new HIV cases in 2020 were among largely cisgender men who have sex with men. 11% of participants reported using any drugs in the last year, including cocaine, crack, heroin, painkillers, methamphetamine, and poppers. Notably, poppers were the most commonly reported drug used at 8%. And just 1% of the sample reported, actually a little less than 1%, reported using any injection drug in the last 12 months. This is kind of a busy slide, I apologize, I'll walk you through it. So here I present data on PrEP care continua for 4 groups of participants. Everybody discussed on this slide indicated that they were either HIV negative or did not know their HIV status. The first set of bars, the dark blue bars, refer to all participants, regardless of gender identity and HIV risk reported. This was just about 2,200 people. In this group, 87%, that first bar there, report ever having heard of PrEP. About a quarter, 25%, report discussing PrEP with a medical provider in the last year. 30% report ever having used PrEP, and 12% were using PrEP at the time of taking the survey. The series of light green bars represents men who have sex with men, and for this presentation, we included in that group cisgender and transgender men who either identified as gay, bisexual, pansexual, or queer, or who indicated that they had ever had sex with a man regardless of his sex assigned at birth, so a trans man or a cis man. This group included 1,288 people. Within that group, 90% of participants had heard of PrEP. Just about a third had discussed PrEP with a provider in the last year. 27% ever used PrEP, and 17% were currently taking PrEP. The gray series of bars represents MSM, so the same group, but just those who were considered at high risk of HIV acquisition based on survey responses. And we define high risk of HIV acquisition as participants who reported one or any of the following in this green box up top. So that's at least 10 sexual partners, use of methamphetamine or poppers, condomless sex with a partner who is HIV positive or whose HIV status was unknown, and or the diagnosis of syphilis, gonorrhea, and or chlamydia. And I see maybe a related question. Oh, the question is the use of poppers trending different from prior years? And I don't have the answer, but perhaps somebody in the group does, or perhaps we can discuss that also at the Q&A. And then finally, So among this group, 98% reported ever having heard of PrEP. 64%, just about 2/3, report having discussed PrEP with a provider. Over half, 56%, report ever having used PrEP, and 40% were using PrEP at the time of the survey. So higher proportion of those who we consider at high risk are using PrEP. And then while this group was small, this sort of pale yellow series of bars refers to HIV negative trans women, which was 50 individuals. And in this group, we found 90% reported ever having heard of PrEP. Just under half, 48%, report discussing PrEP with a provider. 24% ever used PrEP, and 14% were currently using PrEP. In looking at the same groups, but restricting just to those who were not taking PrEP at the time of the survey, we examined reasons for non-use. And just note that on this slide, the scale maxes at 50%, so you can see the differences between each group. I'll call out that the most commonly cited reason for not using PrEP was a perception of low risk. This was higher proportions of other groups, but over 20% of higher risk MSM, which may suggest that perceptions of HIV risk could pose a barrier to PrEP uptake for some. In the same group, we found that insurance coverage or cost was a barrier for about 1 in 10 individuals to taking PrEP. And among transgender women, this yellow bar here, 6% cited that they were concerned that PrEP would interfere with hormone therapy. And then finally, I'd like to share some data specific to our findings on COVID-19. 5% of all participants, the blue chunk of the chart up top, reported having ever had a positive test for COVID-19. We did not observe clear disparities when stratifying by gender identity, but there were disparities by race and ethnicity. 9% of Black participants, 12% of Latinx participants, and 12% of Native Hawaiian and Pacific Islander participants reported ever having a positive COVID test. And in my last slide here, I'll take a moment to orient you to it. So you'll see this pie chart. The dark blue color represents individuals who reported being fully vaccinated against COVID-19. This kind of small light blue section is those who were partially vaccinated, so had 1 of 2 shots of a 2-shot mRNA vaccine series. This pale green represents those who have yet to be vaccinated but intend to be vaccinated. And the black chunk is those who are not and do not plan to get vaccinated. Among all respondents, 96% were at least partially vaccinated, and fewer than 2% of the total, which was about 1/3 of those who were not vaccinated, did not intend to be vaccinated. When we examined the same data by race and ethnicity, we found that potential access issues were revealed. You can see here that 91% of Black participants were partially or fully vaccinated, while a considerable portion intended to be vaccinated relative to the larger group. A large proportion of those who were not yet vaccinated planned to be. And similarly, with Native Hawaiian and Pacific Islander participants, there was a considerable proportion who had yet to be vaccinated but intended to be. This suggests that there's willingness to be vaccinated in these groups, though potential access issues to getting the vaccine, perhaps taking off work, things of that nature. So I'll pause briefly here, look in the chat at questions, and I'm also happy to answer other questions specific to these data. And then if we're all set, I'll let Diana get her slide set up. And so I see a question from Laurie regarding subgroups of PrEP use by race and ethnicity. I did look at those and I wasn't able to fit them into the PrEP section here, but I'd be happy to take a look at those and report out during the Q&A on that data. Michael, these were the only two racial ethnic groups that stood out as having clear disparities in vaccination. So I think there were perhaps 1 or 2 percentage point differences with other groups, whereas Black and Native Hawaiian Pacific Islander people had the most clear disparities. I think those are all of the questions. Let's see.
There's a question from Mark Baker about vaccines by income level.
I see. That's a great one, Mark. I will look into that. I'm not sure, Diana, if you did, but I didn't look into that one yet. Okay. I'll stop sharing and let Diana get set up. Thank you all.
All right, thanks, Mike. Can everyone see my slides okay?
Yes.
Great. So I presented, I'll be presenting today on the 2021 PRIDE Survey supplemental data. And so this project really began with a community advisory board of 9 trans and non-binary people from the Seattle area who were originally convened to advise and guide my PhD dissertation. And so this group proposed new topics for the 2021 PRIDE survey that are important to the trans community, notably questions about food insecurity, experiences of discrimination, and access and barriers to gender affirming care. These questions many of them were adapted from existing surveys, such as the US Transgender Survey and the TransPop study. And other questions were created new by the Community Advisory Board members. In addition, the CAB members revised some of the questions for the core PRIDE survey that Mike just presented on, and provided guidance on analyzing data from our multidimensional check all that apply gender identity measures. So as Mike mentioned earlier, these new questions were added as an optional supplement that followed the core surveillance survey and the raffle. And this research received ethical approval from the University of Washington's IRB. Just to add some terms and abbreviations that I might use during the presentation today, AFAB stands for assigned female at birth. AMAB stands for assigned male at birth. And I'll also be talking a fair bit about gender affirming healthcare, by which I mean a wide range of medical interventions that trans and non-binary people may or may not want, including hormones, surgeries, mental health services, etc. I also wanted to give a brief content warning that my slides will be talking about experiences of discrimination based on LGBTQ identities and race, as well as experiences of sexual and physical violence. So overall, 69% of the core survey participants consented to the supplement for an overall sample size of 1,560. We found that trans and non-binary participants were slightly more likely than cisgender participants to consent, And participants of color were slightly less likely than white participants to consent to the supplemental survey. I'll be presenting several analyses disaggregated by gender identity as well as race and ethnicity. And so I just wanted to present our overall denominators quickly here. I think our smallest groups of analysis are trans women with an N of 56, as well as Native Hawaiian Pacific Islander participants with an N of 18. We found that 22% of LGBTQ participants experienced food insecurity in the past 12 months. We found that this varied by gender identity and by race and ethnicity. Non-binary participants and trans women and trans men were significantly more likely to experience food insecurity in the past year, with over 30%. We also found that Black, African American, Hispanic, Latinx, and Native American participants were significantly more likely to experience food insecurity in the past 12 months. Overall, 24% reported using a food assistance program within the past year. The most common food assistance programs were food banks and SNAP. However, participants also wrote in many write-in responses that included school-based programs, mutual aid, as well as listing specific food assistance programs across Washington state. So next I'll be presenting about experiences of discrimination. In this supplemental survey, we asked questions about lifetime and recent experiences of workplace discrimination, workplace microaggressions, discrimination in a place of public accommodation, and verbal harassment and physical violence. And you can see the exact wording for each of these questions is also provided on the right-hand side of the table. Last week, we also asked about people's self-reported reasons that they felt that they experienced these different types of discrimination. So overall, 58% of participants had ever experienced discrimination due to their LGBTQ identity, and 32% experienced any form of discrimination due to their LGBTQ identity within the past year. In the figure at the bottom, you can see that the most common types of discrimination are workplace microaggressions at 42%, followed by physical violence or verbal harassment at 29%, discrimination in a public place of public accommodation at 26%, and then ever being fired, denied a job promotion, or receiving a negative evaluation at 19%. We also looked specifically at trans and non-binary participants who reported experiences of discrimination due to their trans identity or their gender expression or appearance. And we saw that this lifetime prevalence was pretty similar to what we saw among all LGBTQ respondents. And then among the bottom, we restricted our analysis to just racial and ethnic minority participants, and their reported lifetime experiences of discrimination due to race and ethnicity. And we saw that the prevalence of these different types of discrimination were similar and ranged between 24 and 25%. So on this next slide, we report the prevalence of ever and recent discrimination for any reason. And then I'll also talk through the most common reasons that participants felt that they experienced these different types of discrimination. So again, 69% ever experienced microaggressions in the workplace for any reason. We also saw that physical violence and verbal harassment was quite common at 57%, followed by workplace discrimination at 40%, and being denied treatment or service in a place of public accommodation at 34%. When we look at experiences just in the last year, we see that workplace microaggressions remains quite high at 32%, but other forms of discrimination dropped to 8 to 11%. All right, and I apologize, this is my busiest slide. So now we're also showing the most common reasons that people self-reported that they experience these types of discrimination. Sexual orientation was the most common reason. This was followed by being a woman, gender expression or appearance, and for their weight or height. We see that discrimination due to race and ethnicity was not the most common reason, but that's because the denominator in this table here includes all participants. And we saw on the previous slide that racial and ethnic minority participants did frequently experience these forms of discrimination. We also asked participants questions about their preferences for healthcare. Overall, the majority, or 76% of participants, preferred to receive medical care at a clinic that specialized in trans or LGBTQ health, or from a provider who identifies as LGBTQ. We saw that this varied slightly by gender identity. Notably, trans and non-binary participants were more likely to prefer a clinic that specializes in trans health. Approximately half of non-binary participants and over 80% of trans men and women. Among participants of color, 36% preferred to receive medical care from a provider who shares their same racial and ethnic identity. And this preference was highest among Black and African American participants at 53%. So the next few sections focus on trans and non-binary populations and their access to different types of care. So overall, we saw that people who needed gender affirming care varied slightly by gender identity. But when we look overall at among people who want gender affirming healthcare, we saw that 57% had an unmet need for gender affirming care. We also saw that many trans and non-binary participants experienced barriers to accessing gender affirming care within the past year. So overall, 69% of trans non-binary participants. The most common reasons were financial hardship, lack of knowledge or resources, lack of facilities or providers, and lack of medical access. We also saw that a large number, 17%, provided additional reasons that weren't listed in our original question. And the most common write-in responses were family concerns, delays due to COVID-19, insurance coverage issues, and BMI or body size restrictions for gender affirming surgeries. We also asked a series of questions about participants' healthcare experiences. And the reasons we ask these questions is because prior positive and negative experiences impact people's willingness to seek care and their ability to get their healthcare needs appropriately addressed, whether it's gender affirming care, preventative care, or sexual reproductive care. So overall, many participants had a positive healthcare provider interaction ever and within the last year. 77% said that they've ever had a doctor know they were trans and treat them with respect. However, many participants reported being misgendered or called the incorrect name or being dead named. So 74% were misgendered ever in a healthcare setting, and 51% had that experience within the last year. In addition, 60% had ever been called by the incorrect name, and 37% had that experience within the last year. Half of participants also reported ever having to teach their doctor about trans people in order to get appropriate care. And 24% reported having to do this within the last year. And additionally, a third of participants had ever had a provider ask unnecessary or invasive questions about their trans status that weren't related to their reasons for their visit. Lastly, these two questions really emphasize the importance of using language that is affirming and determined by the patient. So very few participants had ever had a provider ask them what language or terms they prefer to use for their anatomy and body. And 44% had ever experienced a provider using language that they disliked or made them uncomfortable. We also found that many participants had ever been refused healthcare. 29% had ever been refused trans-related care. 19% had ever been refused trans-related care due to their body size, weight, or BMI. 16% had been refused sexual reproductive health care, and 17% had been refused other types of health care, such as physicals and other preventative care. Lastly, and most concerningly, there was alarmingly high rates of verbal harassment and physical assault in a healthcare setting. A quarter of trans non-binary participants had experienced verbal harassment, either from their doctor or in the healthcare setting in general. 12% had ever been treated physically rough or abusive by their doctor or provider. And 7% had ever experienced unwanted sexual contact in a healthcare setting. So despite these very high lifetime prevalences, especially related to violence and discrimination, there is evidence of resilience in the queer community in Washington. So we asked two questions about resilience from the Connor-Davidson Resilience Scale. And these are measures of adaptability and bounce back, respectively. We found that the majority of participants agreed or strongly agreed that they're able to adapt to change and that they tend to bounce back after illness or hardship. When we sum together the scores from these two questions, you obtain the CD Risk 2 score, which ranges from 1 to 10. And overall, the participants had a mean score of 7.78. Which is significantly higher than what has been observed in national samples of the overall US population. And so this suggests that the LGBTQ community in Washington state overall has a higher level of resilience than the general population, as measured by these two questions. We also found that 86% of participants were proud to be LGBTQ, and that 62% agreed that their LGBTQ identity made them feel special or unique. And we saw that this was pride was especially high among particular subgroups, especially non-binary participants, as well as Black, African American, Asian, Native American, and Native Hawaiian Pacific Islander participants. So the study had several limitations. This is a convenient sample. The majority of the sample is from King County. The sample is also mostly white, which really limited our ability to look at intersectional patterns by gender and race. And lastly, COVID-19 is likely a confounding factor, especially related to looking at food insecurity and barriers to accessing care. So in conclusion, we found that many LGBTQ people in Washington live in poverty and experience food insecurity. We also found that people experience pervasive discrimination and violence related to multiple and overlapping aspects of their identity. This is important because we know that experiences of discrimination negatively impact mental health and physical health, as well as access to resources. In addition, our data pointed to a need for additional training of healthcare providers and clinic staff to provide respectful and affirming care, especially for trans and non-binary people. Our study also shows that there's a large unmet need for gender affirming care among trans and non-binary participants. And this points to a need for trans competent LGBTQ identified providers, as well as clinics that specialize in trans care. Trans people also experience significant structural and financial barriers to accessing care. And there's some evidence that that we need to address weight-based discrimination and denial of care for trans patients. I did want to put these findings sort of in the context of policy. And Washington has some of the most robust anti-discrimination laws and insurance coverage laws in the US. And earlier this year, Governor Inslee signed the Gender Affirming Care Act, which affirms that two-spirit, non-binary, intersex, and gender diverse people can be prescribed gender affirming care, and also addresses issues of insurance companies denying health insurance coverage for gender affirming procedures. So I think this emphasizes that hopefully this new law will address some of the remaining structural barriers to access to gender affirming care in Washington, but I think it'll be important to monitor this going forward in time. I also wanted to note that this is the first time we've collected these types of data from such a wide group of LGBTQ people in Washington. The National HIV Behavioral Surveillance Survey does collect these data or similar types of data for cisgender MSM and trans women, but this is the first time we've collected these data for cis women, non-binary people, and trans men. So briefly, just next steps, we're hoping to make these data available in a report format through Public Health Seattle and King County. And we also are hoping to partner with organizations that can utilize these data to support their own work and funding. So I wanted to extend a huge thanks to the amazing Community Advisory Board, my dissertation chair, and everyone at Public Health Seattle King County who helped make the supplement come to life. And I also wanted to thank the Northwest Center for Public Health Practice and the American Sexually Transmitted Diseases Association for providing funding for the Community Advisory Board. Oh, and we still have lots of time for questions. So thank you all for staying through this presentation. I'm happy to take questions on my section of the talk, and also to open it up to questions about Mike's talk as well.
I've been entering some answers to questions in the chat. So if you asked one, it might be in there with your name.
Thank you, Mike.
Mike, for the sake of the recording, maybe you can read the questions and the answers.
Sure. Yeah, so let's see. So Laurie asked about PrEP use in race and ethnicity. And a quick tabulation of HIV negative and unknown HIV status, MSM, showed that the Native American and Alaska Native identified individuals had lower current or ever use than other ethnic and racial groups. The other one in the chat that I answered was from Mark about vaccination and income. And it looks like it likely is an association. So in the lowest income group, which was those who reported under $15,000 a year, 92% were at least partly vaccinated, and 7% wished to be vaccinated but hadn't yet. Whereas in the highest income group, which was those who reported over 50,000, over 99% had been at least partly vaccinated, and only about 0.5% wanted to but hadn't yet. So definitely didn't do the regression, but I suspect there's a strong association there. I see that Andrew has a hand raised. I don't know, Diana, if you want to.
Yeah, this is for Mike. Based on your vaccine survey, was there any further input on why some were outright, no, I don't want to take the vaccine?
We did ask those questions, and I didn't examine those for this survey, for this particular presentation because of time constraints, but I'd be happy to look into those and talk with you offline. I'm not sure if others have looked at it, but I haven't had a chance to examine those yet.
Thank you, Michael. That's a great point you added in the chat, that Black LGBTQ people also want Black healthcare providers.
Well, we're giving other people a chance to think of their questions. Diana, let me ask you, have you gotten back to your jury group the findings yet? And what kind of thoughts did they have?
We haven't had much dedicated time to look at these findings yet, but I'm very much looking forward to doing that soon.
And another question maybe both of you can address. What would you recommend we do differently in 2022?
I suspect, Diana, you might have some good insight on this with your relationship with the CAB.
Differently for the Pride survey or just in general?
The Pride survey is what I was thinking of, but
Mm-hmm.
ideas on other policies or programs for sure. We have the HIV epidemic month. We've been, trying to get low barrier clinics and do other things, but we're always open to what we should do to end the epidemic and how we should run the Pride survey too.
Yeah, I think it would be nice to ask these questions again in the future. I do think especially some of the questions around food insecurity are undoubtedly impacted by COVID-19. And I think it would be really interesting to see how that changes and if it changes over time. I also sort of after the Pride survey was implemented, thought it might be useful to ask additional questions about evictions and some more detailed questions related to housing security. And then Corinne, just to answer your question, we did not ask about where folks are getting their gender affirming care. Although I would also be curious to see that answer.
And just for the sake of the recording, in addition to Corinne's question, she put a nice accolade there saying thanks for the excellent work, Diana and Mike.
Thanks for the chance to present. Oh, there's a comment from Lori that it might be interesting to ask where people have had positive experiences with gender affirming care. That would be great to know.
Agreed. Yeah, there's definitely lots of room to ask these really important questions.
What do you all think about adding questions on alcohol use?
Yeah, I think it would be great to ask about alcohol use. I also know that some of those types of questions are asked in other surveillance surveys, like the Behavioral Risk Factor Surveillance Survey. And so in that way, it might be nice to see, you know, how this sample differs from some of the population-based studies that also ask about sexual orientation and gender identity.
So Mark gave a ditto to the addition of alcohol, and Julia gave some more accolades to us doing the survey remotely. And I think that if there's no additional questions, I'll encourage you all to hit the reaction button and give a round of applause, the way that we do in Zoom with the claps. And thank our presenters for 2 excellent presentations. I think that this has been a really good year for our Pride survey, that we've gotten a lot of really important data. So thank you so much.
Oh, there is a question about where the recording will be available.
Chris Joss, are you able to answer that? I think that
I'm here, Susan, but I'm just filling in for Danielle. I don't know where she posts the videos for the Lunchbox.
Okay.
Most likely on the CFAR YouTube channel.
Yeah, before 2018, I think there was a dedicated site on the CFAR webpage, but now there's a link to YouTube presentations, and the Lunchbox presentations are mixed in with the new faces and other talks, but I think they're there. Thanks, Chris.
Yeah, I'll see if I can find the link and put it in the chat real quick.
Great. Okay, we'll be meeting again in November and in January. And I can't remember November's talk, but I think Steve Early is talking in January. Does anyone else know what's happening in November? I'm sorry, I didn't look that up to start, but hope you all can join us again then, and we can conclude the Lunchbox for today. Thank you.
Thanks, everyone.